So I have 31 questions on your exam. So my advice to you is to pay attention.
John, position your camera real.
Yeah, that's my advice to y'all. Okay, so today's lung cancer. Lung cancer is a cancer that, when I was teaching this maybe like 3 or 4 years ago, we would have had only a certain amount of drugs, maybe like 8 to 10. Unfortunately, that number is more like 30 now because there's a lot of targeted therapy that's involved with lung cancer. There's a lot of monoclonal antibodies, but more than anything, there's small molecule inhibitors. So these are like drugs that you take orally. So there's a lot of oral agents now for lung cancer that have been approved in the past, I would say 2 years, 2 to 3 years. So you won't have the responsibility of knowing all of them. There will be some that are very important that are a part of clinical practice that I'll make sure you guys are aware of, and you know which ones that are important in that way. When you're looking at lung cancer, you see second leading cause of cancer and leading cause of death. Of course, it's one of the cancers that, of course, affects men and women, so it's not limited to just one sex. But as you can see, whether you're talking about males or females, it's at the top of the list as far as new cases are concerned. So it's secondary to breast cancer in females and prostate cancer in males. That's why we have so many patients that we see on a consistent basis in our thoracic medical oncology division at Memorial Hermann. The unfortunate thing about lung cancer is even with the advances in the medications, we still have it as the top leading cause of death by far. When you look at all of the cancers, trumping breast and prostate. You see double in prostate when you look at males. So it's a tough cancer to treat, and it causes a lot of death. So there's a lot of research that goes into lung cancer, just like breast cancer. Prostate cancer, I feel like there's not as much research going on with prostate cancer, but it is a more indolent, not as a lot of times when it's diagnosed, it's going to be diagnosed in the earlier stages, so you end up with better outcomes because it's diagnosed in the earlier stages. Lung cancer, conversely, is diagnosed in the later stages, so that's why you have more patients that die of lung cancer, because it's very common for a patient with lung cancer to be diagnosed at stage 3 or stage 4. And you understand, if I say a patient is diagnosed at stage 4, then that means that we can't cure them. They have metastatic disease, and that means they're going to be on something for the rest of their life, essentially. So looking at tobacco, the misconception sometimes is that tobacco, if somebody has that smoke, to have lung cancer. Actually, there's about 15% of patients that have never smoked a cigarette in their life, haven't even been exposed to secondary smoke, and they can get lung cancer. So it's not just limited to patients who smoke. Now, if you're talking about cigarette smoke, of course, it's still there, but there's a lot less cigarette smokers in the United States now compared to even 10 years ago. So because the cigarette smoking has went down, we haven't seen theoretically a decrease in the amount of lung cancer. So even though cigarette smoke was a high link to lung cancer, it's not going to be the main reason. It's not going to be the only reason why a patient, even though it's a risk factor. Asbestos, which associated with mesothelioma. I know everybody's seen the commercials. You get with the lawyers, try to sue whatever chemical company is locally in your area. Somebody has died or has had lung cancer, mesothelioma. So you do see that in about 5% of the cases. It's not super common, and actually mesothelioma and asbestos like that. Aside from older buildings, you're really not getting exposure to asbestos anymore. It's like below the health code. So this is like maybe 20 years ago you would see. Occupational risk and air pollution a little bit less. This one important because I always talk to you guys like one of the first things you need to know is what is the histology of lung cancer. So there's 4 histologies you guys need to be aware of. They all have different nuances and different things that you should know. So squamous cell and adenocarcinoma are your vast majority of non-small cell lung cancer, because I'm going to teach you guys about pretty much 4 different types of lung cancer today. There'll be non-small cell and there'll be small cell, but within non-small cell, there's 3 different types. So non-small cell has squamous, adenocarcinoma, and large cell. So those are your 3 that are within non-small cell. Now, when I say small cell, it's only small cell. So that's the first thing to learn today. Your 4 types of lung cancer. You have adenocarcinoma, which is a type of non-small cell lung cancer. You have squamous cell carcinoma, which is a type of non-small cell lung cancer. You have large cell lung cancer, also a type of non-small cell lung cancer. And then your 4th and final type, which I'll talk about it at the end, is small cell lung cancer. So does anybody have any questions?
You said the squamous cell is the vast majority?
So squamous, adenocarcinoma, they take up 70% of the cases of non-small cell lung cancer. And then large cell is the minority when you talk about non-small cell. And then small cell in itself is rarer than non-small cell, but is in a class of its own.
Okay. So none of them molecular markers, none of that goes with, okay.
The molecular markers are coming soon.
Okay.
Okay.
So the large cell is still under the non-squamous.
That's correct. Non-small cell.
Non-small, that's separate.
Large cell is under non-small cell. That's correct. Does everybody understand it?
And we'll learn small cell later, you said.
I'm gonna end with small cell before you guys do your 8 class assignment.
Okay.
So the small cell is the rest of the 15%?
No, actually, all of these together, that large cell. So you look at you got the 70%, you got the 85%. That small cell, yeah, usually about 10 to 15%. So it's like much rarer. So you won't really see a lot of small cell, but it's there. But here you're gonna see this is the vast majority. So 70% of them are these 2. So this is what you're gonna see probably in the community. Most of you guys, if you get this, unless you're in oncology like me, you're gonna see a patient with one of these. Adenocarcinoma, squamous cell, you're gonna see a patient with one of these. Large cell and then small cell, both of which take up about 10 to 15% of the cases. Those are rare. Yeah. And these are actually the major ones. There's actually there's some sarcoid, there's a couple of very, very rare kinds, but these are the majority. It's small cell, large cell, adenocarcinoma, and squamous cell. So any questions? Okay. So when you're looking at squamous and adenocarcinoma, I got the asterisk by these 2 because even when we start going through the guidelines, if y'all looked, I posted the guidelines so you guys got to see the foundation and where a lot of this information is coming from. These are by far like how the guidelines are written. So they're written that if a patient has either non-squamous or they have squamous, and then there's a treatment path for squamous and there's a treatment path for non-squamous. And you're talking about non-small cell lung cancer. So these are the two important. Okay. So you're looking at squamous. Does tend to be one that's a little bit slower as far as growing. This one is pretty much all of the patients that smokers, the squamous cell, they're smokers. And that's in contrast to the adenocarcinoma, which can actually be, you can have patients very frequently that don't smoke at all and get adenocarcinoma. So that's why I was telling you that when you look at like smoking, 40% of the cases could be adenocarcinoma, which could have no link to smoking. Okay, on top of that, when you look unfortunately with adenocarcinoma, you look at prognosis, it's got the worst prognosis when you compare it. So squamous cell is a bit better treated, if you will, compare it to your patients who get adenocarcinoma. So adenocarcinoma also, the proliferation is a bit different. So the proliferation, the reason why proliferation is important because the faster it grows, the more chance it has to metastasize. So if the proliferation is higher and it grows faster, it causes more mortality and morbidity. So if you're comparing adenocarcinoma to squamous, adenocarcinoma definitely has that proliferation rate, and Ki-67 is higher, meaning the cells grow faster, double faster. So with large cell, really not anything really special about large cell other than the bulky tumors. Prognosis very similar to adenocarcinoma, which is both of these are worse than squamous cell. And like I say, with the adenocarcinoma, understand that one cannot smoke. It's not necessarily associated with smoking. So that's an important thing to take away from when you're differentiating these types. And I'll go ahead and mention it now, even though I'll mention it again a little later on. Small cell, almost purely associated with smoking. So almost all of the patients with small cell lung cancer are smokers. And squamous cell does have a link to smoking as well. Now your molecular markers, when you're talking about non-small cell lung cancer. So there are a host of them. We'll kind of go through, you don't have to necessarily know some percentages. What I want you to focus on with the molecular markers is drugs that are associated with the molecular marker. Okay? So KRAS, which have you guys remember KRAS? Remember us talking about KRAS?
It's on there, what happened?
What y'all remember what disease state, like what disease state would KRAS have a implication in? So, y'all remember talking about colon or rectal cancer at any point in time?
Yeah.
So, with colon and rectal cancer, the KRAS is very important when you talk about metastatic disease because it's a switch that can be turned on or off and cause a drug to work or not work. So if you have a patient that has a KRAS mutation in colorectal cancer, then actually it stops the EGFR directed therapy from working. In lung cancer, it's routine to check for the KRAS mutation. If you check for the KRAS mutation, once again, it's the smokers with the adenocarcinoma. So that small percentage or that those kind of outliers, and that's why you only see it in a lower percentage of patients with non-small cell lung cancer. They can have this KRAS mutation. And sortilin is actually like top of this LUMACRAF. This is actually one of the main drugs that we use for a KRAS mutated non-small cell lung cancer patient. So sortilin. So EGFR, going back to colorectal cancer, because you're gonna notice that because you have like this adenocarcinoma, which is the same histologic cell type that you see in GI malignancies, you're gonna see that some of the medications that are used are similar as well. So with the EGFR mutation, which is HER2 or ERBB1, the erlotinib, the osimertinib. The osimertinib is the newer version of the drug that can target mutated EGFR. Erlotinib is the older, but both of those are very important as far as therapy is concerned. They're standard of care, erlotinib and osimertinib. And they target mutated EGFR. So right now we have KRAS, which sortilin, yes.
What's TKI?
Tyrosine kinase inhibitor.
Oh,
Tyrosine kinase inhibitor. That means they inhibit the phosphorylation of a specific kinase that once activated causes proliferation, metastasis, and growth of cancer cells. Something unfortunately, maybe I should have been talking about in your chemistry class. Go ahead.
You said that it targets the mutated EGFR.
That's correct. Specifically, you got exon 19 being the most commonly mutated portion of the EGFR genome. So we good right now? We have sortilin, okay, with KRAS, and now we have erlotinib and osimertinib with EGFR. Okay, so now we're at HER2. So where have you heard HER2 before?
Breast cancer.
Breast cancer. Okay, and breast cancer. You had a question?
I wanted to, you said earlier that erlotinib
Uh-huh.
and
Osimertinib.
they target mutation. I forgot what you
Mutated EGFR, exon 19.
Okay, that's what I wanted to.
Yep. So when they have a HER2 mutation, this is the second subtype of the EGFR, which EGFR is actually, human epidermal growth factor receptor. So the second subtype, because there's 5 different subtypes of that particular receptor, is HER2. So HER2 is what we talk a lot about in breast cancer. There's about 20% of breast cancer patients that will have a overexpression of HER2. And in lung cancer, we're actually going a step further and we're looking at a mutation in the HER2 receptor. So if that mutation is identified, it's appropriate for us to use something like trastuzumab deruxtecan or adotrazumab intensive. These are, do y'all remember, I don't think we talked about trastuzumab deruxtecan, but I know that I talked to you guys about adotrazumab intensive. So y'all remember what that one is? So this is Kadcyla. This is Kadcyla, and this is HER2. These are both monoclonal antibodies that target HER2. And they're indicated in breast cancer, but as you can see, they also have utility in lung cancer as well. So now we're at 3 mutations. We have KRAS, we have EGFR, and we have HER2. Okay. A little bit least common, but still very, very prominent, is the ALK pathway. Okay, the ALK pathway, only about 4 to 8% of patients, but one of the very common drugs you'll see is crizotinib. Okay, crizotinib is a small molecule inhibitor that you'll see with the ALK pathway. It's specifically targeted there. Once again, this is something that we check on a routine basis to identify if patients have these mutations, and then you have all of these drugs that come into play if they have the mutation. And you get some crossover with the ROS1 rearrangement, where you can still use crizotinib, but you start adding some others in as well. So the ALK pathway and the ROS1 rearrangement, you'll see some consistencies on the drugs that can be used in one versus the other. But like I said, crizotinib is one that's kind of like a catch-all, as well as a certificate. So these 2 are the ones that we use like most clinically right now, but those have data also. They have clinical trials that will show, they have category 1 recommendations that we'll talk about a little bit later. But understand that the crizotinib covers ROS1 rearrangement and ALK, as well as the certificate.
So do we use each of the drug as monotherapy or like a?
Yeah, they're actually used in monotherapy. So there's some dual therapy regimens that we'll touch on, but most of these, if you have an ALK pathway, you can use one of these 5. One of those 5. Okay, so PDL1. Do you guys remember about PDL1? Okay, so PDL1, we were talking a lot about pembrolizumab when we were talking about breast cancer. So pembrolizumab still holds a lot of weight in lung cancer as well. But in contrast, atezolizumab is actually more commonly used in lung cancer when you start to compare them. There's also a drug called durvalumab, which I didn't mention here, but we'll talk about actually when we start talking about the therapies in the different stages. Okay, durvalumab. So the 3 that you want to know from here: pembrolizumab, atezolizumab, and durvalumab. Durvalumab, we'll talk about it a little bit later. Okay. So combination therapy. When you're talking about patients having a BRAF mutation, the BRAF mutation has 2 different levels that you can attack it at. So the dabrafenib and trametinib are like your combination therapies that we usually recommend if you have a BRAF mutation. The BRAF mutation, of course, the dabrafenib targets the mutated BRAF. The trametinib is actually a MEK inhibitor, MEK inhibitor. So MEK is in the same pathway as BRAF, and trametinib targets that. So that's why they're together. We usually attack this at the same time in 2 different places. This is important. This combination is also approved, as well as vemurafenib, are also approved in melanomas, where we first identified these BRAF mutations. But now we know that these BRAF mutations show up in lung cancer as well. So we'll also screen to see if they have a mutation in BRAF to see if they will qualify to use dabrafenib and trametinib, or possibly single agent vemurafenib. So any questions on the pathways so far?
Both pathways and D1 very
B600E, what about,
What pathway is the other one?
what pathway, which one?
The monotherapy?
Oh, sure. So monotherapy is actually BRAF only. Okay, it's just BRAF only. So there are actually multiple MEK inhibitors, but they haven't entered the realm as far as approval in lung cancer yet. So if you go to melanoma, there's multiple combinations depending on what drug company it is that have formulated a BRAF inhibitor with a MEK inhibitor. So vemurafenib has a coupled MEK inhibitor called cobimetinib, but it's not approved in lung cancer yet. It's only approved in combination therapy for melanoma. All right, so that's why I told you like a lot of drugs. So we talked about the EGFR, the different mutations in the EGFR. You see that they're actually very, very extensive. I only mentioned erlotinib, and of course we got the osimertinib, but you see that there's afatinib, there's quite a few, gefitinib, there's quite a few that are actually in that space. The only ones I want you guys to probably take away from is osimertinib and erlotinib. And if you notice, the erlotinib with the bevacizumab is something that's specifically for, that's one of the combinations, not a lot of combination therapy, but that's one of the combinations in the first line if you have an EGFR mutation. Bevacizumab specifically, and yeah, I don't think we talked about that one much, but we really probably at least touched on it in colon cancer. Targets a pathway called VEGFR. Okay. So with the last three, because these are like extremely, I mean they're rare. A lot of them are rare, but the one I want you to take away from is the red rearrangement of the cabozantinib. The cabozantinib with the red. Now you see all of the genetic abnormalities that can happen in lung cancer that need to be screened for. Right? That need to be screened for.
So out of everything on this list, you only want us to know those two drugs?
In which one?
This one?
No, I gave you wolf food for this. I only skip two pathways.
Which one do you want us to know from the pathway?
The ones that he had in his document, and then you go down and look at the pathways, and then you underline those drugs.
Right.
Okay.
Yes.
For the break,
The bracket, yeah.
you said it's not only
It's for metastatic melanoma also, that's actually where it was first approved for. But now it's approved, now you have data to support its use in patients who have a BRAF mutation, B600E, and non-small cell lung cancer. Yeah. So vemurafenib single agent is approved, it has data, and you got dabrafenib with trametinib and BRAF B600E mutation, and non-small cell lung cancer. So any questions before we leave?
If we could just go through the drugs so we can.
You said you wanna go through the drugs.
The numbers right next to the drugs, what is that?
The numbers that next to the drugs are actually referring to the guidelines, and they like move you to the actual, they'll move you to the actual reference where the drug was, how the drug was studied, or they'll move you to a caveat about how the drug can be used clinically. Yeah.
Just to confirm, can we quickly go through like what drugs you want us to know from each?
Okay. Okay. So the sorticid, okay, for KRAS. So for KRAS, sorticid, Lumakras. Erlotinib and osimertinib, which also you will see on the bottom, because osimertinib not only has initial treatment, it has maintenance treatment, subsequent treatment. So it's like one of the ones that's probably like your staple as far as clinical practice right now today in EGFR mutated non-small cell lung cancer. HER2, adenotrastuzumab intisine, and the famtrastuzumab deruxtecan are HER2 mutated. With the ALK pathway, specifically crizotinib and crizotinib. Okay. Same thing with the ROS1 rearrangement, the crizotinib and the crizotinib. Okay. With the PDL1, the pembrolizumab, atezolizumab, and durvalumab, which is later on in the presentation.
You said something about the Cruzultimab.
What about the other? Well, I mean, the crizotinib. The crizotinib is the one that's got that ROS1 rearrangement and the ALK activity, so you can use it in both genetic abnormalities. Okay. So BRAF V600E, both the brafenib with the trametinib combination and the single agent vemurafenib. And the NTRK123 mutation, I kind of skipped this one, as well as the MET exon 14 skipping. I skipped that one to the RET rearrangement with the cabozantinib. I said that's the only way you know how to do it.
Oh, so only for the RET rearrangement, just carbosantinib
That's correct.
and but not, don't worry about the two above them?
The two, yeah, the NTRK123 and the MET exon 14 skipping, you can skip those. But I included them because I wanted to be complete. You probably don't never see these drugs, but to be complete, I wanted to have them there as far as like where they're placed in the Okay? So screening is important because at a point we didn't know that we could screen. So we came up with this screening recommendation with low dose CT scan. Okay? So with low dose CT scan, what I want you to take away from this is being able to stratify out the groups. So if I give you a patient, you be able to identify who's in the high risk group that will qualify for the low dose screen. Okay? When you start talking about the moderate risk and the low risk, the strength of the recommendation of getting the annual low dose CT becomes controversial. But with these two groups of patients, I want you guys, if I give you a patient, because maybe this patient is not diagnosed, I might give you a rolling case where I give you the same patient multiple times. And the question may be, would this patient qualify for low dose CT scan? And maybe they already got diagnosed with lung cancer, but theoretically, maybe you could have caught it earlier if you would have started screening them. So I want you guys to understand the age group, the amount of cigarettes, pack years they need to smoke, as well as like when they stop smoking, if they stop smoking, or looking at the patient's smoking risk, and if they have risk factors like associated with smoking, as well as, if you notice, we don't talk a lot about family history. So it's usually genetics or smoking. Because you still have, even though not every lung cancer associated with smoking, you saw 80+%. It's going down a little bit, but even if you're looking at the new numbers, it's at least 70% of cases have some either identification of secondhand smoke or have somebody directly smoking for years and years associated with increased risk. So these two patient populations are the two patient populations I want you guys to be able to identify. And if you can identify these patient populations, they do have a recommendation for low dose CT scanning to try to pick up the lung cancer early.
So is it their primary care doctor that would be checking on
Yes.
them annually, that would be able
Yeah.
to check this?
This would be the responsibility of the primary care doctor to have a patient that's maybe above the age of 55 and has this 30+ year history of smoking cigarettes and can order the low dose CT as they start receiving it. So they still wouldn't necessarily see an oncologist, but they would be able to get the low dose CTs to identify hyperdensities or opacities in their lungs that could possibly lead them to get treatment early versus late.
So this screening that came about,
Is this a newer recommendation?
Probably in the past 3 to 5 years.
that was my question too.
Yeah, 3 to 5 years, yeah, so not super old, but yeah, it's now some solid data that can be stood upon. Yes.
When you say low dose CT scan, do you mean exposure wise or or?
Yeah, exposure rise, because there's like a certain amount of radiation that the patient can be exposed to, and that had to be taken into consideration when they said they were gonna start. But you gotta think about it, I'm 55 years old, you start scanning me with a CT every year, you're actually increasing my risk of possibly developing cancer too, especially if you have me with a full dose while I'm getting a good amount of radiation. So you do a lower dose of the radiation so you can continue to keep scanning the patient and not cause more harm to him.
And with the 15-year, smoking cessation, does the risk of getting lung cancer go down if it's been longer than that?
Well, so like for instance, so you said less than 15 years. If you're going above, then you kind of then you start to it becomes protected, like where they've had a long period of time. And, you have a patient that has a good amount of age on them to have had over a 15-year period of not smoking and still had 30 pack years of smoking. You see what I'm saying? That means that's at least 45 years, and you got to put 45 years on top of 55. So it's extremely old patient to really even fall into that category. Yep. And that's really what this was put here for. It was put here because technically, you could pick up a patient that's I guess technically you could have started when you were really young smoking, and that's why you maybe can catch that type of patient. Let's say you started when you're 15, where you smoke until you from you 15 until you 45, you now have 30 pack years of smoking, right? So then, let's say you stop, and then they pick up on this at age 65. So now you had 15 to 45 you smoke, but then you had 20 plus years that you have not been smoking and nothing has happened. So then they're like, well, is it really beneficial to screen this patient?
Is there a recommendation for moderate risk?
Moderate risk is controversial. So that's why I said the only one that you really can lean on is high risk. Moderate risk is like, they've done studies to show it might be beneficial, it may not be beneficial. That's why I didn't put it recommended. It's more of a debate. So this patient does have a identifiable increased risk, but the coverage and the data does not lead to being able to definitively say they can benefit from low dose CT. So that's why I mentioned this because this does establish a risk, but it's tough to like really justify doing a low dose CT scan on a moderate risk. Only on these is it been definitive that it's appropriate. Any questions? Nothing right now? Okay. Okay, so your clinical presentation. So of course you have a host of different things that can happen. Most common thing is coughing. Everybody is coughing these days, so it's not really something that everybody cough. So this is not one that's too sensitive or specific to lung cancer. The dyspnea, when you have that painful or coughing up blood, now we're starting to talk about some serious issues. Post-obstructive pneumonia is when you have like a pulmonary lesion that the lung cancer is actually causing you to have an infection. So this is usually, unfortunately, that's one of the ways that it usually is going to show up as that post-obstructive pneumonia, where a lesion is clogging up a bronchiole or clogging up a tube or inflaming the alveoli, and then that causes you to have a pneumonia. And then you come in for the pneumonia, and they continue to keep treating you with antibiotics, the pneumonia never subsides. And then that's when the biopsies occur, and you start having to talk about the You guys know what a pleural effusion is? Have y'all heard that term before, pleural effusion?
Yes.
Okay, so what's a pleural effusion?
That's space between the ribs and the.
So your lungs, both of your lungs are in a big sac. That sac is called the pleural, okay? If you have an effusion in the pleural, okay, then the effusion is fluid. So there's fluid around your lungs, and you have pleural effusion. So pleural effusions occur in a lot of different scenarios. Lung cancer is one, but the pleural effusion can, very, very commonly patients, if they are extremely sick or they're retaining a lot of fluids, guess what? They get fluid around their lungs. They also can get fluid around their heart. Okay, that's called a pericardial effusion. But effusions are just like pockets of moisture and liquid around an organ. Okay. So, another thing, clubbing, hoarseness, what are these signs and symptoms of? These two. Hypoxia, okay? So patients who are chronically hypoxic will have things like clubbing, and then the hoarseness, because actually, depending on where the lung cancer is, it actually can affect the vocal cords, it can affect the airways, get very, very narrow. Y'all talk a lot about asthma and COPD. Some of the symptoms we talk about asthma and COPD are actually very similar, especially at the end stages. Perineoplastic syndromes. Perineoplastic syndromes are actually syndromes that will mirror what's happening with the cancer. So I think probably the first thing that you guys, and unfortunately if you've had people in your family that have had cancer, you witnessed them have something called cachexia. Do y'all know what cachexia is? Cachexia? So cachexia is like wasting. It's like when you can have HIV or AIDS associated cachexia, and you have cancer associated cachexia. It's like when somebody, let's say somebody was 175 pounds, and then months after they get after the diagnosis, they're at 120 pounds. They're losing muscle mass, they're losing weight, and wasting away. So that's cachexia. That's a perineoplastic syndrome that happens. So when patients have cancer, and you notice they really start losing a lot of weight, it's not really because of the medication, it's not because of anything other, they can still be trying to eat maybe too. They can be eating, but they waste, and it's a perineoplastic syndrome. So that's that weight loss and fatigue.
So the cachexia is the weight loss?
Yeah, cachexia is the weight loss. Weight loss is just like a common way or lay way of saying cachexia.
Can you spell
Cachexia-
that?
I know, I
Yeah,
think
C-A-C-H-E-X-I-A. Cachexia. C-H, C is in cat, A is in apple. Yeah, C-H-E-X-I-A, cachexia. Okay? So Cushing's, hypercalcemia. Hypercalcemia is another one that I mentioned. So hypercalcemia, host of different things with that one that we have to watch out for, but specifically with hypercalcemia, we start looking at fatal cardiac arrhythmias associated with having extremely high calcium levels, and we'll go as far as to give patients bone modifying agents like bisphosphonates or rank ligand inhibitors to bring down the calcium. Because if a patient has that perineoplastic syndrome, they will continue to have this out of control calcium level until you address it. And it's directly related to their cancer. So as long as their cancer is under control, they're walking around with a dangerously high calcium level. So you have to give them medications to secondarily bring their calcium down. So yeah, the three there, the anemia will follow it. So I give you these three. And not only do you have to know how you treat it, but also what's associated with it. So cachexia and weight loss. What are some things you can treat? How can you treat a patient for cachexia? What do you think some things you can give? Or some things you do give?
TPN,
Hmm?
you give them, are they already, put them on some type of nutritional?
Yeah.
So, it's not as much as them eating as much as it's like that. Like I say, this perineoplastic syndrome is more internal. So we go as far as to, and early on we'll give them things like appetite stimulants. So that's the first thing we'll do. So appetite stimulants. So that would be things like cycloheptadine, dronabinol, nabilone in very, very serious cases. Okay. Megace. The only reason we don't use as much Megace is because Megace what's the toxicity associated with Megace? Very, very dangerous. And it's coupled with the toxicity or a common thing that happens with cancer patients. So cancer patients are hypercoagulable, meaning they throw clots very common. They have a lot of DVTs, they have PEs, they have superficial venous thromboembolisms. So they have a lot of different clots that are forming already because they have cancer. Cancer causes them to do Megace also causes clot formation, so we're very mindful when we have patients, especially if they're metastatic, on using Megace because of the clot formation. But if they have very severe cachexia, we will sometimes still try to use Megace. So right now we have cyproheptadine, we have dronabinol, nabilone, which is a C2 formulation of the dronabinol essentially. We have Megace.
Is it too much to run?
Let's see, yeah, that's fine. Yeah, so we got the cycloheptadine. Oh. I have some in my car also, that's crazy.
We can't sound like that.
So we talked about cachexia, we mentioned the Megace. Okay, we mentioned the dronabinol. Also, we got the nabilone. Okay, we got cyproheptadine. Okay. I mean, one is still out there too. Okay. Mirtazapine. They're all very important when you're talking about cachexia and the weight loss and the wasting associated with cancer. So that is for hypercalcemia.
Is there any anti-psychotic?
It's for anxiety, depression, but it also can stimulate, your appetite also. So hypercalcemia. All right, so we know we have our bisphosphonates. Okay, we have our rank. Okay. What's the rank L inhibitor?
Whatever Dr. Bosa.
This is dealing with the bones, you know.
Prolia, Prolia.
So Prolia is one formulation of it. When you're using it for hypercalcemia, you're using the other formulation.
So you know, phosphate class.
It's called XG. Huh? XG, yeah, XG. So, XG. Okay.
You take with Fox?
Hmm?
Is it the one you take with Fox?
Which one?
This German,
Dronabinol?
yeah.
This is in the refrigerator. Yeah, this is Marinol. This is in the refrigerator, and this is like a synthetic THC capsule essentially. Yeah, synthetic, yes. So with hypercalcemia, loop diuretics with force, with hydration is also something you can do to bring down the calcium levels, yeah.
Oh, so that's the Delta 8. The Dronabinol.
Yes. Oh, Delta 8, no, it's not Delta 8.
Is it, or is it Delta 9?
No, this, the dronabinol, it is the synthetic form, but yeah, it's nothing you can get over there. This is C3.
Yeah.
Yeah, so the Delta 8 is not even where it's supposed to be like dronabinol. So yeah, the loops plus hydration. So, what's special about calcitonin? Calcitonin is brings the calcium down the fastest out of all of these. Tachyphylaxis. Y'all remember what that is? So tachyphylaxis is when you give a drug multiple times, and then the drug stops to work. Typically, you get about 2 to 3 days of activity with calcitonin. Okay? Tachyphylaxis. So loop diuretics and hydration, so that's pretty much forced diuresis to where you're trying to, you increase substantially the amount of fluid that's in the body, and then you push out a lot of this calcium with your kidneys. Okay? So you got the rank L, you got the bisphosphonates, and the rank L is Xgeva. Xgeva is dosed at a higher dose and more frequently in this situation where you have hypercalcemia. And then you have calcitonin, which you can use up front, but it has tachyphylaxis, so it's only active for about 2 to 3 days. And then finally, we talked about the loop diuretics and the hydration. And then the last one of the ones we talked about is the anemia. So what would y'all do for the anemia?
Earn supplements. Give a pill. Do you look at the hemoglobin levels first?
So checking the hemoglobin levels and noticing the patient is definitely has anemia. What are your options? So you give them oral iron or IV iron, okay? Oral iron, or if they don't respond to oral iron, you can also give them IV iron, but you do need to check their iron studies to make sure that this is an iron deficiency anemia, which very commonly it is. I have a host of patients that are on IV iron. You don't want to give ESAs, especially if the patient is in a curative state. And why is that? What's an ESA first of all? Erythropoietin stimulating agent. So that's darbepoetin, okay, or that's epitin alpha. And why would we not want to give those if a patient is in a curative state? So these ESAs, prior to 2 years ago, or it's been 5 actually now. The ESAs had a REMS program that limited their use because they were associated with recurrence and progression of cancer. Because the ESAs not only feed and cause more red blood cells to circulate, they cause the cancer to proliferate and grow better as well. So ESAs are not appropriate, even if the patient does have the anemia, because they can actually feed the cancer. So the IV iron, the PO iron, and then finally, blood transfusions are typically what we do to address anemia in these types of patients.
Quick question for the bisphosphonate and the rectal. Usually they take a little longer
Yes.
for them to decrease the hypercalcemia.
They do.
Is that recommended in terms of?
Yeah, so what you do, is that the rank L or the bisphosphonate, whichever one you want to use either or, you're gonna give them maybe weekly for the first month. But that's while the calcitonin is going, for the first couple of days to get it down acutely, and then maybe giving the patient hydration. But it's gonna take them a couple of days to get down. But usually, like you can get usually with the hydration, the hydration is the quickest way after the calcitonin stops working. But you can't hydrate the patient at home as much. So you either have to continue to keep bringing them back to the clinic and giving them hydration and having them on diuretics for that first week. And then the bisphosphonate or the rank L usually will kick in after about a week. And you have to continuously give it weekly, typically for 3 to 4 weeks before you start giving it monthly. And then if you give it monthly, it'll keep that calcium level down throughout the time. It just needs that week or 2 to start working.
Excuse me, sir.
Yes.
For addressing the anemia, is there any need to add the vitamin B12?
Well,
B12.
it's not this anemia is not typically associated with deficiencies in vitamin B12 or the folic acid.
Okay.
Yeah.
And so, do you want us to know like the dosage for like the PO, IV formulation, or just know that it's a
No, I'm not asking for doses. I just want you to be able to address it appropriately.
those three.
Just those three. All of them are perineal plaque syndrome, but just those three. And I chose those three for visual reasons. Okay, so sites as far as like metastatic disease, brain, bone, and liver are really the common places you see lung cancer spreading to. Bones, of course, like causing these fractures and pains. Most of the time, patients can have altered mental status when they have brain meds, causing them to act differently, be lethargic, sleepy. In very extreme cases, they can have a complete personality change. All kinds of things can happen when they have brain meds. And then, of course, just like complete liver failure, when you're talking about having involvement in the liver. Oncologic emergencies and superior vena cava syndrome, or SVC, and cord compression. So out of these two, both oncologic emergencies, but we'll talk about cord compression just briefly. Okay, so cord compression. So cord compression, does anybody have an idea of what's going on here? If I say a patient has a cord compression? Hmm? So, yeah, so think about,
Just spinal cord for you. The disc.
okay. Yeah, so these vertebrae. Patient has metastatic disease. The cancer infiltrates the vertebrae. Okay? Cancer infiltrates the vertebrae. So now they have cancer on their spine, right? So when you have this, this decreases the integrity. Okay? So as it decreases the integrity, you can get a patient that now looks like this. What I didn't draw. So there's your spinal cord actually through is protected by the vertebrae, which of course is an extremely long nerve essentially. So as you get this decreased integrity right here, this one and this one here
Fused together?
no, they touch each other. And as they touch each other, they squeeze and pinch the spinal cord. And they squeeze and pinch the spinal cord, they actually can cause the patient to become paralyzed. And this is extremely painful.
Wow.
They'll stay paralyzed for the rest of their life if it's not addressed. And this is an emergency. The patient can die of this, of course, as you might imagine.
So they have to get surgery, right?
They have to either get emergent surgery, if it's not a severe case, you can possibly treat them with steroids. And then finally, what you can do is something called kyphoplasty. So now, you look at that place that's like damaged. Yeah, so the spinal surgeon that originated this, he was at MD Anderson when I was doing my fellowship. So I saw him do this. They have a biodegradable cement that they'll put here and pretty much remake your vertebrae to where it was prior to you having the cancer. So they scoop out all of the cancer and they replace it with a biodegradable cement on your spine, and it's called kyphoplasty. And it then restores the functionality of it where you just have an artificial portion of it. And then like you're not paralyzed, you're not having pain, and then they've gotten rid of all of the cancer locally in the therapy. So you can use steroids, or you can have kyphoplasty. And those are like the two major ways you treat cord compression.
Can you spell that? The kyphoplasty?
Kyphoplasty.
Dr. Wilson, you were there, that sounds expensive. What have you seen that actually went through with that type of?
Oh, this is standard of care across the world now.
Oh, okay.
It just like, it started like about 12 years ago.
Okay.
But it's since like, as he's presented this, like now, this is any hospital, that's an NCI designated institution probably has a spinal surgeon that can do kyphoplasty, and been taught how to do this. So you have a patient with spinal cord compression, they'll put the biodegradable cement on the spine after all of the cancerous areas and necrotic areas are removed. That's pinching your spinal cord, and then it'll restore, the functionality of where that particular vertebrae should be. Yes, sir.
How long would the biodegradable cement last?
It's like, once it sets, I mean, it's like true cement. You know, you got patients that are 15 years out and haven't had to have another surgery. Okay. So with the staging, I always say, I'm not a pathologist, you guys are pathologists. I know these stages because I continuously come in contact with them, but I don't think it's necessarily something you need to memorize and know. You just need to be able to refer to the chart to be able to stage them and give them that opportunity. Okay? But, just to talk briefly, just the basics. Of course, when you're talking about the T, N, M staging criteria, the T is always focused on your primary tumor. The larger it gets, or the more infiltrative it is, the higher the T. When you start talking about the N, this is the amount of lymph nodes and the location of the lymph nodes that are positive. If you have more than one lymph node, you're always gonna be at least an N1. And you get progressively worse as the lymph nodes get in different areas and more dangerous areas of the body. And then finally, you're typically the M1 or you're M0. So you have metastatic disease or you don't have metastatic disease. In essence, it's what type of variable?
Excuse me, sir.
Yes?
This question is just based on this cord compression, this
Okay.
outside this scenario. Does it have any kind of impact on their psychological?
Core compression is really focused on their mobility. So
Okay.
it's all about mobility.
Okay.
Having a core compression can cause the spinal cord to become tense, can cause them to be paraplegic or quadriplegic, depending on how high. Cause like, the higher up it is, the more limbs are now paralyzed when it compresses.
So about the staging, how do you want us to, you said don't worry about the staging, but how do you?
I want you to be able to, given the stage, to be able to interpret how to stage the patient.
So we gotta know this chart, we gotta memorize it.
No, the chart will be given, you need to understand how to get the chart. And be able to stage the patient.
Yeah, okay, can we do a scenario?
Well, we're talking about now, we're talking about metastatic disease versus not metastatic disease. And I said, what kind of variable is it?
And
Said what?
Nominal.
That's correct.
Say
It's
it
nominal.
what?
I said, what kind of variable is having metastatic disease? I said, you can be M1 or M0. Those are your
Oh,
two
either one
choices.
or the, okay, got you.
Either M1 or M0. So it's
No,
nominal.
yeah, yes, sir.
It's a nominal variable.
You either there, you there. Remember? When we do our class, that's what we just, that catch was.
Which one?
Let's figure it out.
So, talking about the stage, this is what I was talking about. So you have a patient that's T1, so we go back up there, a patient that has less than a 3 centimeter tumor, and they don't have any lymph nodes deposited, and they don't have any metastatic disease, then they're stage 1A. We go down, patient that has T2 tumor, so it's above 3 centimeters, they have 2 lymph nodes that are positive, and they have 1 lesion on their vertebrae. They're now M1, which means they're immediately stage 4. Okay? This one. So, any T, when you start looking at this patient, dry versus wet. That's why I went through that whole spiel about pleural effusions. So, a patient who has stage 3B disease that doesn't have pleural effusions is treated differently than a patient with stage 3B disease that has pleural effusions. If they have pleural effusions, then we treat them like a metastatic patient. Does that make sense?
Why is it a-
So what's pleural effusion again? Let's go, what's pleural effusion? There's fluid around the lung. So patient at the same stage, stage 3B, okay? But one does not have fluid around their lungs, meaning they don't have pleural effusion. One does have fluid around their lungs, they do have pleural effusion. One is considered dry, stage 3B dry, one is considered stage 3B wet. The patient who's stage 3B wet has pleural effusion.
Okay.
So you
The
kind
patient in stage 3B wet is treated like stage 4 patient.
So somebody with metastatic.
Yeah.
Exactly. Does everybody understand that? Okay. You know, nothing really to do here other than just understanding the medius thynoscopy with the biopsy is typically the gold standard of how we'll diagnose patients. You need to do that to get some actual tissue so that you can establish if it's one of the 4 histologies. What are the 4 histologies?
Oh, you're talking about the squamous?
What are the 4 histologies?
Oh, squamous, adenocarcinoma, large cell,
And
small cell carcinoma.
Okay. So not mentioned here, and what is done is screening for our molecular markers, okay? Our molecular markers. So what molecular markers are we screening for?
All those ones at the
Rough
top.
and.
What are
There's a bunch.
they? EGFR, HER2, KRAS,
ML4, PD-L1,
ML4, ALK, ALK.
PD-L1,
ROS1,
ROS1 rearrangement,
PD-L1,
PD-L1,
BRAF,
BRAF, B600E.
and then RET rearrangement.
RPT, yeah.
Yep, yep.
Wow.
And you said it's all a part of, imaging or?
Histology.
Histology.
No, it's.
Our pathway.
No, so when a patient comes in, they theoretically have lung cancer suspicious, we're gonna do a biopsy with the medius thynoscopy, we're gonna do a sputum cytology, but what I'm talking about is the fact that in addition to all this imaging, we're gonna check for those molecular markers that we talked about earlier, because we need to identify up front if they are possibly gonna be candidates for those drugs depending on their stage. Okay? So the Eastern Cooperative Oncology Group, 0 to 2, is talking about how this is a performance status.
What
So
did you
this
call
is
them again?
The Eastern Cooperative Oncology Group. Eastern Cooperative Oncology Group. They come up with a mechanism to identify patients' performance status. So the performance status is very important in lung cancer, as you're gonna see when we start talking through the guidelines. The higher the performance status, the less a patient can move and tolerate treatment. So if their performance status is 4, that's the worst of it. That means that a lot of these therapies we may recommend, that patient can't technically tolerate, so they're not a candidate for that. So the Eastern Cooperative Oncology Group's performance status rating is very important when we choose therapies. Okay? If you notice, if they're 0 to 2, they have favorable prognostic factor. If they go 3 to 4, which these patients can't move on their own very well, they probably are paraplegic or have a wheelchair, walkers, require assistance to do normal daily activities, they have a poor prognosis because they can't tolerate therapy.
So because it's a poor prognostic factor, you automatically activate KRAS?
Because of the poor prognostic fact, because they have a poor prognosis, they don't have a very good performance status, we might opt to choose one of the therapies that's not as toxic. Because there's chemotherapy that's implicated and used in lung cancer, and then there's targeted therapy, and targeted therapy tends to be better tolerated. What we talked about thus far throughout this whole lecture is targeted therapy. I haven't mentioned one chemotherapeutic agent yet. Chemotherapy is using lung cancer is hard to tolerate compared to the therapy that we talked about previously. Okay, so now we're getting into the therapy. Now we're getting into the therapy. So, we have surgery, we have radiation, we have chemotherapy, we have targeted therapy. Those are the things we have. Does that sound familiar?
Yeah.
Okay, because those are the same treatment options we had in breast cancer, missing one thing, right? There's one thing that's not used in lung cancer that's used in breast cancer. Y'all remember what it is? So there's no endocrine therapy here. So there's no hormonal components to patients' lung cancer. There's no utility for using estrogen-directed therapy. There's no utility for using selective estrogen receptor modulators. But the surgery, the radiation, the targeted therapy, and then if we want to separate out immunotherapy, then we could. Immunotherapy would be like your pembrolizumab, durvalumab, or atezolizumab. So with surgery, especially in the earlier stages, because we do feel that we can cure those patients, they're always gonna have surgery on the table. There's 3 different types of surgery you can use. The sleeve lobectomy is what's preferred, so you can underline sleeve lobectomy. Pneumonectomy, what do you think happens with a pneumonectomy?
Is that lung?
Yeah.
You're taking away the lung?
A lump,
Remove the whole lung, the whole thing. So a sleeve lobectomy, if you've seen the diagrams of lungs, you know the lungs are essentially
like 2 steps.
But before you make that decision, are they gonna be candidates for, transplant?
there's no utility with, for a lung transplant in patients with cancer. The only place where that theory shows up is in liver cancer. So there is a utility for liver transplant in patients with liver cancer. But in lung cancer, no. And if you notice, part of it is that there's such a high risk of it being metastatic, even if you can't identify it. You don't have a strong leg to stand on if somebody diagnosed with lung cancer, like giving them a lung. When you maybe have a patient on the donor list that has no malignancy, that's in the same clinical scenario, because that patient with lung cancer, their 5-year, and I didn't harp on it when we were doing staging, but you see the 5-year survival of a patient with lung cancer, even early on, is relatively low compared to other cancers. Yes.
Why you were a patient that had this thorax something, and they were bleeding, they were kind of sucking the fluid out, and he survived for at least, he survived for almost 8 years.
You talking about sucking, having pleural effusion?
Yes, they
Well,
were always taking it out.
Yeah, that fluid continues to collect. If you remove it, it continues to collect. If you don't remove it, the patient pretty much suffocates. Yeah, because the fluid starts to squeeze the lung to the fact it can't expand anymore to put air in the patient and to oxygenate the blood. But if you continue to keep using the Denver cath, which is a catheter to remove the fluid, then they can survive even with pleural effusion. So sleeve lobectomy would pretty much be like, if your tumor was here, then they would remove this lobe. If your tumor was here, then they remove this lobe. Pretty much preserving, like, you know, they may only decrease your pulmonary function by 33 to 35% every time they do it. When you do the full pneumonectomy, you actually pretty much decrease their pulmonary function by 50% altogether. You take it out fully one of their lungs. So you still got functionality in that lung if you, or 100% of that lung's functionality is gone when you remove the whole lung. So that's why the sleeve lobectomy, same prognosis when you think about what happens afterwards, is still better than the complete pneumonectomy. Now, if you have tumor that's infiltrating multiple lobes, then they go ahead and will do the pneumonectomy, because now you start to be where you try to leave one lobe versus like 2 lobes, when you need to do it more than one lobe, like if you have a tumor that maybe is spread and it's in both of these lobes, then they may just go ahead and remove the whole thing. But if it's only one lobe, they definitely will opt to do the sleeve lobectomy. And then finally, the wedge resection will be like if the tumor is on the outside of your lung, you sometimes can get away with doing this. So they'll actually cut into the lung and just remove the tumor, make sure they have, y'all remember what positive versus negative margins are? Positive margins versus negative margins, y'all remember which one's good? Like a positive is like a positive scenario, or negative is like a negative scenario, y'all remember? Negative is good, positive is bad. Positive is bad because that means that there's still some tumor at the edge of the threshold that was removed. Yeah, so wedge resection is not necessarily recommended because of the fact that this has a higher risk of recurrence. So it's got the highest risk of recurrence when you look at all three surgeries.
So when you're doing all this removal thing, are they opening up stuff with oxygen for the rest of the day?
No, this is just one of the lungs.
So they survive on the MS.
Use a functional lung.
Yeah, you can function one lung. Yeah, you just like, I mean, of course, like your capacity is gonna go down, but yeah, you can function one lung. A lot of people have to function one lung. Okay. So we talked about, we talked a little bit about performance status. Unfortunately, sometimes patients, they can qualify for surgery, but physically they cannot tolerate the surgery. Okay, so that's when we start talking about a patient. You were just talking about where they're gonna be on oxygen. They're not gonna feel comfortable doing a surgery, a pneumonectomy, or even a sleeve lobectomy on a patient who already has pretty low lung function. So if they already aren't breathing well, then they need to have a conversation. A lot of these patients, they're breathing fine, they just have the cancer, but if they got COPD on top of having lung cancer, they may not be a candidate for surgery. Yeah.
So they just die like that?
Well, I mean, we still give them treatment. All the systemic treatments are still there. This is just the surgery is not there. And honestly, you know, it's unfortunate for these patients, but when surgery it helps, but in lung cancer, it's not the cure-all, be-all. See, it's not the cure-all, be-all. That's why the morbidity is so high compared to all the other cancers. Even when you do the surgery, you're still like not out of the woods. You still like need to kind of watch what's going on and monitor them for years and years. Radiation doesn't have as much of a utility in non-small cell lung cancer. Has some activity in unresectable patients, which we just talked about. Unresectable patients are patients that can't tolerate surgery. It has utility there, but outside of there, it's not as strong. And I'll go ahead and tell you now, in small cell lung cancer, it's standard of care. So all patients with small cell lung cancer, if they're not metastatic in the extensive stage, will receive radiation with their chemotherapy. And conversely, with small cell lung cancer, surgery doesn't have a strong utility. So they pretty much get radiation and chemotherapy, and surgery they don't even receive. Okay.
So a question,
Mm-hmm.
in your monectomy, when you remove all the,
Yep.
section of the lung, how patient do it?
Well, they have one lung.
Just
It's not, yeah, so like if they had contralateral, so whenever there's cancer on both lungs, they're considered to be metastatic, so they're not a candidate for surgery. They can only get the pneumonectomy if it's only unilateral. It's gotta be one. So chemotherapy, of course, like I was talking about, metastatic disease, that's the standard of care. Adjuvantly or neoadjuvantly, you can do chemotherapy, but combination with definitive radiation is gonna be when it's unresectable. So unresectable could be where the tumor is or who the patient is. If the patient cannot tolerate having the surgery, they're considered to be unresectable, and now they become a top candidate to get chemoradiation. If the patient can tolerate surgery, but their tumor is in a place to where it cannot be resected, and a common reason why you have a patient with a tumor that cannot be resected is if it's extremely close to a blood vessel, or it's encompassed by a blood vessel. but the tumor can be in the lung tissue, but it's grown so much that it traps itself in a blood vessel. And if it does, they don't feel comfortable removing the tumor because the patient can bleed out from the tumor being removed. So the location of the tumor is also very important. You understand?
What's the prognosis for patients who can't have surgery before tolerate radiation? Does it report this?
That type of patients, typically they would be like in this space. Their 5-year overall survival is about less than 10%. You're probably looking at more like between 9 to 12 months of survival if they can't do radiation or surgery. All right. So talking about the resectability, and then like looking at patients who are these stage 3B patients, they are the ones that fall in that place where we probably would not do surgery on them. Now, what do we need to ask if they're stage 3B? On top of being stage 3B, what's important about how we're gonna treat them?
The pleural effusion.
Whether drop. So you know if they have pleural effusion or don't have pleural effusion. That'll help dictate some of the things we do as far as systemic treatment is concerned. All right. So yeah, just talking a little more about adjuvant radiation. What's positive margins again? So if they do the resection, and at the edge of the resection, they notice that there's still some tumor at the edge of the resection, that's now a suboptimal resection that's gonna require radiation definitively. So that's one of the cases where you definitively have to do radiation if there's positive margins after the surgery. On top of that, you start seeing patients who have features that increase the risk of metastasis. They're gonna qualify for radiation. We already talked about patients having stage 3B disease, definitively getting radiation. If they have diseases on their chest, the mediastinum, then they're actually a candidate for radiation. And then finally, when you start talking about chemotherapy, 4 cycles. 4 is gonna be the magic number. So you get down here and you start looking at these treatments, you see a lot of them. 4 is typically your magic number. Now, we had already talked about this, but the PD-L1 status, very important. The EGFR, very important. The ALK rearrangement is very important. So those drugs that we talked about earlier, they can be used in stage 1, stage 2, stage 3, and stage 4. So they're used everywhere. That's why I feel it's appropriate to learn them. Because I'm not even, if I went to metastatic disease, this thing gets extremely crazy. You know, so we'll just focus on the perioperative systemic therapies. What is perioperative? What's another name for perioperative treatment?
Before surgery.
Neoadjuvant. Okay. So the ones I want you to know, okay, preferred non-squamous and preferred squamous. If I say preferred non-squamous, what am I talking about? What's non-squamous?
Non-small cell, the non-small.
What's non-squamous? Non-squamous. Adenocarcinoma. This patient has adenocarcinoma, or this patient has large cell. That's why I want you guys to know the histology. Because if you see, if I tell you one histology versus the other, the recommended treatment is actually different. So if I say adenocarcinoma, and I'm talking about the preferred, I want cisplatin with pemetrexed for 4 cycles. Alright? Now, if I say squamous, then that's when I want the cisplatin with gemcitabine or cisplatin with docetaxel. Still 4 cycles. Okay? Still 4 cycles. How is it so far? How's it feel?
For the non-squamous, it can be adeno, whatever, or landmark, or the R-log.
Or low. Or. One or the other. So up here, these 3 regimens. And under these three regimens. Cisplatin, pemetrexed for non-squamous. Cisplatin with the gemcitabine or cisplatin with the taxotere for squamous. And we're about to stop on non-small cell, and we're gonna go to the treatments of small cell. But before we go there, I do want you guys to know these three, which I've already mentioned them. So you got the osimertinib, the atezolizumab, and the pembrolizumab. So what type of genetic mutation do the patient have to qualify for the adjuvant osimertinib? EGFR. Okay. And you know the atezolizumab and the pembrolizumab are indicated in what?
PD-L1.
PD-L1. And the last drug is durvalumab. So durvalumab or Imfinzi, okay, or Imfinzi, that's actually a PD-L1 inhibitor also, okay? But the caveat to it is not only does it bind the PD-L1, the PD-1, it also does CD8. So it's actually a dual acting agent. Okay? It's important because it's like your main type of drug you be using in consolidation treatment in patients who are unresectable stage 3. Unresectable stage 3. So we use this very commonly in this patient population for patients, and it's actually in combination with chemotherapy.
You said this is for stage 3 patient?
Unresectable patients. The Pacific trial did the study essentially to show its benefits. And this one is actually important because this kind of just shows that the PD-1 expression, the PD-L1 expression wasn't as important when you think about like, because actually this is like above 25%. I think one of those is actually supposed to be going the other way. This one is above, this one is actually below. But with the durvalumab, they would get it in between that days 1 through 42 with the chemo and radiation. So that's actually this one is important because it's that unresectable patient. They used to only get chemo and radiation, and now they get the durvalumab with chemo and radiation. And the whole point of that is that at one point we thought the PD-L1 expression was directly related to how well the drug worked. So this study not only showed that it had a benefit with chemo and radiation in those unresectable patients, but also that the PD-L1 expression had nothing to do with this activity. So it worked in patients that had a lot of PD-L1 expression and patients that had very moderate or small amounts of PD-L1 expression. And the p-value is 0.001. So what does that mean? What is the chance of the type 1 error occurring? When we're comparing the median time to death of distant metastasis being 23.2 months versus the 14 months.
Yeah,
Yes, sir.
it is.
No?
It's statistically
We say
significant.
95%.
There's a 0.1% chance that a type 1 error occurred when comparing these two variables, the control arm with the treatment arm.
That means it's good.
No, that means it's 0.1% chance of a type 1 error occurring. What's the medically acceptable chance of a type 1 error occurring? Nope, that's the power.
Our
5%.
0.05%.
0.05. 5% chance of a type 1 error occurring if the p-value is less than or equal to 5. 0.05. If I say the p-value is 0.001, then it's a 0.1% chance of a type 1 error occurring, which is well above
The 5, right?
the threshold.
This is good, this is good.
So that's good, right?
Yeah, I mean,
We
the
just want to
study,
say
that's
it.
why, the drug is FDA approved because of this. I'm asking you to give me the intensity of the link between the benefit. You get to say it's statistically significant when you're a P1 and not when you're on rotation. Alright. So just hit this up. So you see, we kinda talked about this at the beginning, 14%, about 14% of lung cancers are this small cell, but you see it's associated with 25% of the deaths. And that, and to put that in perspective, that means that this one is by far like the most virulent in morbidity and mortality causing lung cancer out of all of the different subtypes, small cell. You see, smoking, almost 100% of the patients have some aspect of smoking associated with what they're doing. So also, when you look at the staging, it's a little bit different. What we expect is that a patient will be either on the limited stage or the extensive stage. So the limited stage or extensive stage is how they truly diagnose. It's not necessarily type, it's not necessarily stage 1, stage 2, stage 3, stage 4. The thing that always gives it away is that the cells are like these small blue round epithelial cells. And they're small blue and round when they have small cell lung cancer. Proliferation, very, very tough to treat. Not, like I say, surgery has no utility. They've done multiple studies to show that surgery is not very beneficial unless it's in extremely early stages, and you very seldom catch this in the early stages. So unfortunately, the standard of care is radiation as well as chemotherapy. And when you're looking at the prognosis, untreated patient diagnosed with small cell usually will die within 3 months. 3 months. Okay. If they have limited stage, and this is with treatment now we're talking about, you see their survival is right a little bit less than 2 years, and their 5-year survival is less than 20%. And when you start talking about extensive stage, I mean, that's very tough. You see, 2% of patients typically are alive at 5 years after if they're diagnosed with extensive stage. We're talking about almost a 98% mortality rate at 5 years if they're diagnosed with extensive stage small cell lung cancer. And I already alluded to this, but surgery, very, very seldom used. Only time you maybe can get away with it if you have an early stage 1 patient. But that, like I said, is very uncommon for them to be diagnosed. See, less than, you're talking about less than 5% of the cases will be early stage diagnosis stage 1. Most of the time, it's gonna be stage 2, which is limited stage, or stage 3, and then all the way up to stage 4, which is extensive stage. So with limited stage, the current chemotherapy and radiation, that is the standard of care. That's what definitely want you to like understand and know when you're talking about small cell lung cancer. This is the standard of care. Now, your preferred regimens. Now that we're here. And remember, this is gonna be with radiation. You got your cisplatin with your etoposide, and it's really just 2 different dosing schemas of the cisplatin with the etoposide. Alright, you got the day one cis, which is typically gonna be both of them, and it's just like one has got a bit more aggressive etoposide dose, and one has a bit more aggressive cisplatin dose. They both have been shown to be about the same when you're talking about efficacy, and that's gonna be with radiation. It's gonna be with radiation. So cisplatin with etoposide for sure, and then cisplatin with etoposide, whether you have a higher dose of the cisplatin, a bit lower dose of the etoposide, or vice versa.
I mean, how do you make the judgment call?
Patient comorbidities and toxicity. Anybody have an idea why you might want to use carboplatin with the etoposide instead of cisplatin? Once again, we're going back to the patient. So patients that have very, very poor renal function or have borderline renal function, we would definitely want to err on the side of giving carbo versus cisplatin, because cisplatin causes a lot more nephrotoxicity than carboplatin. So that carboplatin regimen with the etoposide at 100 milligrams per meter square is also very important as far as utility to be able to use if you're giving a patient that has some baseline comorbidities associated with their kidneys. Finally, as our end with small cell, is the prophylactic cranial radiation. So that's something that's a standard of care. It has been shown to be positively effective at treating patients with limited stage small cell lung cancer. The reason why is because there's a high propensity to spread to the brain. So rather than even giving it that opportunity, they would go as far as giving 25 grade of prophylactic cranial radiation to try to prevent the spread of lung cancer to the brain when they have small cell lung cancer that's being diagnosed at the limited stage. So that is where I will end today. There's a, you notice there's a lot paid
You
I'm
want
talking
all
about.
of this ready for Friday?
Yes, sir.
Like usually the plan.
Yeah.
Outside, we used to
I'll give you my two.
how do you meet that? How do you get
Well, so you're gonna notice, because I had so many questions, I had to think about it when I was, yesterday when Dr. Eden texted me about how many questions I have in the exam.
Yeah.
So there'll be obviously a good amount that will be associated with lung cancer, but there'll be just as many that are talking about supportive care, which I think is probably even a little bit more than some of the stuff with lung cancer. Because pretty much, I really couldn't see a lot of these questions being asked on NAPLEX, but what I'm gonna ask you is something that be asked on NAPLEX, because I'm gonna be focused as much or more on supportive care with all of these therapies that I've talked about. Okay, so nausea and vomiting. Because I talked to you, I've mentioned cisplatin a lot of times. Cisplatin is, of course, like the top of the list as far as like drugs that you should use, that you should give acute and delayed nausea and vomiting prophylaxis. You should get all patients to get cisplatin and that type of prophylaxis. So of course, I'm gonna want you guys to create a full regimen. And a full regimen does not only have the chemotherapy, it has the supportive care that goes along with it. So that means you need to understand that you need to use a 5-HT3 antagonist, a steroid, also using the neurokinin 1 antagonist. You need to understand you need to use those prophylactically to treat this patient's chemotherapy, nausea and vomiting acutely and on the delayed side. Also even employing things like olanzapine if needed. The guidelines will give you the opportunity to use all of those. So I expect y'all to be able to do that too. So your in-class assignment, not only will you have to choose the correct regimen to use for the patient according to what we talked about thus far, but I also expect appropriate supportive care on top of that.
So it sounds like we'll be using our notes for the assignment.
Wait, you think what? Don't go by
It's right now.
It's
It's doing it now.
Whoa! Dr. Hunter, you coming in
Give us
hot.
a break, we gotta use the restroom. Can you
Y'all can use the restroom, make sure you get the work. The assignment is posted, the link is gonna show up in about 20 minutes. It's due at 12 o'clock.
We have to say justice.